David, I can't hear you if you are speaking.
David said he was having some issues unmuting Ricky.
Well, I think Dave is having some technical difficulties, but we certainly can introduce ourselves. Hello, everyone, and welcome, and thank you for joining our DOAC debate. Alicia, Lichvar, and I will be debating the pros and cons of DOAC use. My name is Georgina Waldman. I am currently a cardiothoracic pharmacist at Massachusetts General Hospital. I actually did my pharmacy school at the University of Pittsburgh with Alicia for a period of time, and then decided to go to the West Coast for my residency training, where I completed a PGY1 and PGY2 in solid organ transplant at UC San Diego Health. I'm currently at Massachusetts General working in the hearts and lungs, and I'm very excited to be debating the cons against the double DOACs.
And my name is Alicia. Just as Georgina said, I graduated from the University of Pittsburgh, where Georgina and I had a significant amount of overlap. I did my residency training there, and then I did my fellowship at the University of Cincinnati before working at the University of Illinois at Chicago for 4 years. And then I took a tip from Georgina and decided to go out west. And now I'm at the University of San Diego Health in La Jolla in California. So we're really excited to have you guys with us for this DOAC journey that we're about to go on. So I'll walk you through. Neither of us have any potential conflicts of interest. No one paid us to give this talk. We're just extroverted enough and decided to overcommit the week of BCTXP. It's no big deal. We're also going to be talking about some off-label or so for today's presentation, we're really only going to be talking about non-valvular atrial fibrillation and also VTE. With regards to indication, we would not be talking about mechanical circulatory support, mitral valve replacement, or valvular atrial fibrillation. So today's learning objectives really are to discuss the available literature surrounding DOACs and solid organ transplant. Again, list the available lab tests that might be deranged, describe the current landscape of appropriate DOAC use, or maybe not appropriate DOAC use, depending on who's talking, and then navigating the nuances and pitfalls of different anticoagulation options for our patients. So with that, I'm ready to rumble. Are you ready to rumble, Georgina?
I am ready to rumble. Why don't you kick us off?
All right. So if you would have told me in 2016 that DOAC would be somehow my specialty as a transplant pharmacist, I would have told you no. But here we are, 6 years later, still talking about them. 3 papers, an ATC platform, a couple webinars later. And for us still, there's a lot of contentious points between DOACs and warfarin. Warfarin came out in 1954. And prior to that, it actually had a different name. It was known as rat poison. And we know the pitfalls of warfarin. We know that it requires frequent monitoring and it impacts quality of life. I just came from VAD clinic and it brought me back. I was in a time capsule to pre-DOAC era and it gave me nightmares. There's drug, disease state, diet interactions, the need to bridge if patients fall too low, and potential increased bleed risk depending on who you're giving these agents to. And really in the current era of anticoagulation, really we have a new first-line agent. We have a new kid in town, and those are DOACs. They have major benefits, and that really derives from their wide therapeutic range and overall less diet and disease state interactions that can occur because of that. And in a recent survey, actually, that Georgina and I both are authors on, about 94% of programs use these agents after transplant. So why are we still having this debate? And mostly it's because there's this comfort in the familiarity, and the familiarity for the longest time has been warfarin. And when we surveyed these pharmacists and said, hey, like, why aren't you using DOACs? Like, what's influencing your prescribing patterns? Really, it came down to renal function, drug-drug interactions, and then for some at that point in time in 2019, insurance coverage. But when we think about DOACs, honestly, we have over a decade of data, and not just transplant data. We have large tens of thousands of patients at this point have been done through very rigorous clinical trials with regards to these agents. In addition to that, we have very delineated pharmacokinetic differences that we know and understand between these agents, thus kind of delineating maybe who they should be used in and who they should not. And we know that there's basic differences in dosing because of those pharmacokinetic differences. So these are just very overview slides of the dosing and reduction indications per package insert. But what's new, I guess, this team around, is that in solid organ transplant, we have data. We actually have 10 trials, which for us, that's actually really great. This is a lot of data for transplant land. I'm surprised there's not a BCTXP question on it. And for us too, what's even better than just having our single cohort studies, we have comparative trials. What's been published so far has been in liver, kidney, and heart transplant. And you can see here, these are patients that were started a little bit more chronically post-transplant as opposed to acutely, but there's no difference in thromboembolic rates. There's no difference in clinically relevant bleed. And if there was a numeric or a statistical difference that was found, actually, it was higher bleed in the Coumadin side. So unfortunate news for Georgina, but more data is coming. We are both a Pitt alumni, so we cannot remiss. Yes, I made this meme. You're welcome. From the Pitt data that's coming in that was recently presented at the 2021 ISHLT. Pitt was the originator. Pitt has been doing this since 2010, since I was in pharmacy school, and they're forthcoming with their lung data, which is propensity matched in a 1-to-1 ratio. And for us, this is going to be the largest thoracic experience that's coming down the pipe. And given its propensity matching, it's a little bit of a more robust experience also. And they found also no difference in the rate of VTE and no difference in major bleeding. So for us, we're not done having data, but this 50 shades of anticoagulation anxiety still persists, right? It's not binary. It's always a gradient in transplant. It always has to be something. And for us still, there's these nuances that we have in our practice. And really, it comes down to therapeutic drug monitoring, drug reversal and bleeding management, and then patients that are just outside of the guidelines that weren't in those original decades-old clinical trials. So my job today is basically to remind you where that line in the sand is, and maybe should you adjust that line if you haven't already, and that a vast majority of the patients that you see are probably DOAC eligible. And don't be afraid necessarily, because the benefits at this point are going to be vastly outweighed. So with that, I'll hand it over to Georgina.
And surprisingly, this is my first slide. I am here to tell you that I do think DOACs are great. I am not going to argue that contention point that DOACs are a fantastic agent and perfect for your straightforward, perfect organ function, average size patient with a very simple medication regimen. Does that sound like any of our patients? None of the wonderful complex patients that we get to work with every day. I'm here to remind you that there are other options in your toolkit for anticoagulation. When things go from clear black and white to the most gray. Yes, when things are black and white, there's certainly a role for these newer agents. And that's where their straightforward lack of monitoring can be helpful for our patients. However, we have warfarin and enoxaparin, which have been on our side since 1954. The amount of history and experience in nearly every situation that we have with these agents is not paralleled in many other aspects of our transplant experience. So As a brief review, I included here and listed some key pharmacokinetic parameters for both of the medications, warfarin and enoxaparin, and several components which will come up again and again during this presentation, such as their metabolism parameters and pharmacokinetic parameters such as Tmax and half-life. This really is our happy place. This is the definition of the comfort zone because these agents are our standard of care. Listed on this slide are the FDA approved indications for warfarin, which covers literally all aspects of anticoagulation indications, including specific anticoagulation intensity that we can modify depending on the indication, such as our mechanical valves. Enoxaparin is still limited in its indications. Yes, this is not a slide of enoxaparin indications. However, we do have monitoring with our anti-10A levels to allow for monitoring in expanded indications. I've also included trials because we've got data. The data that I pulled was from the early 90s because these medications have been around for so long. I included the trials that you may not know well in terms of name recognition, but you know these trials as they're part of laying the foundation of these agents of our standard of care. You know what the results of some of these are. We have one placebo-controlled trial of SPAF published in 1991, which established superiority of warfarin over aspirin in preventing stroke in patients with atrial fibrillation. This trial had 1,300 patients and found a reduced risk of stroke in compared to placebo. We also have the next trial comparing enoxaparin to heparin for VTE. These were found to be equally efficacious and safe while allowing outpatient access to medications for a patient, allowing that bridging to happen outside of the hospital. And the last trial here highlights the safety of these agents over longer durations, as it shows decreased risk of recurrent VTE over 2 years when patients are maintained on anticoagulation with these agents for 6 months instead of 6 weeks. Now, this presentation is going to focus on the downsides of the DOACs and how other agents like warfarin and enoxaparin have upsides that may balance them out. But it is not to say that these agents are not without risk. This includes reversal for the many unpredictable events after a transplant, monitoring for those gray zones that we often encounter in our patient population, acknowledging the drug interactions that we do encounter, but also knowing what's going on with these patients by being able to monitor and discussing our extreme populations where we have the comfort of experience and monitoring. These downsides of DOACs, they all add up. I'll be the voice of reason throughout the presentation, reminding you that you can use DOACs for more. However, there are times when you shouldn't. But I won't pretend that our options don't have downsides too. And we'll be discussing those as well. So Alicia, let's kick it off with round one.
All right, so round one leads us to procedural pauses and bleeding reversal. So just as a reminder, if you haven't kind of stumbled through this data already, our patients tend to need anticoagulation more so than our typical non-transplant individual. And that's for a lot of different reasons. Our risk of VTE is higher across liver, kidney, heart, and especially lung transplant with our IPF patients. And that's really driven by a lot of factors, including malignancy, major surgeries, sometimes obesity, renal dysfunction, older age, and then immunosuppression, specifically the mTORs that we can use. In addition to that increased VTE risk, we're also seeing a higher prevalence of atrial fibrillation within our transplant population compared to our non-transplant individuals, and that manifests itself in its need for anticoagulation. And this is a problem because at some point, your patients are going to require a biopsy. At some point, they're going to require maybe some dental work. At some point, they might want to get a lap band and look all skinny post-COVID. Who knows? So when we think about all these procedural bleed risks, we really need to be thinking, well, where do they fall? Low, high, or minimal. For the most part, our transplant-related procedures are usually and generally considered high risk. Fortunately, the American College of Cardiology recommends set durational pauses of our DOACs across all of the different agents that we have. Generally, this is guided by our known half-lives, both in the setting of normal renal function, then also CKD and ESRD. As you can see, there are some patients, especially as we fall below that 30 range, we're really extending out the DOAC and how long we have to hold it to account for the increased half-life of those drugs. Specifically, where we might run into issues are patients that have lower creatinine clearance, but on our side is we do have anti-10A monitoring or DTT monitoring to tell us, okay, if we held it, do we hold it long enough for a scheduled biopsy? In addition to that, we have a very robust data from non-transplant individuals, a study called the PAUSE study that looked at 3,007 patients with non-valvular atrial fibrillation who are going for any type of procedure were put on this protocol, basically mimicking the American College of Cardiology guidelines, in which low-risk procedures, DOACs, were held for a day. High-risk procedures, they were held for 2 days or longer, pending creatinine clearance. And you can see the overall bleeding risk was low relative compared to the expected bleeding risk that we would see after any surgery, whether it be minor or major. For the most part, the rate of arterial thromboembolism was also quite low, and that was also mirrored within our high bleed risk procedures. So we have a substantial N, albeit in a non-transplant population. So the question is, okay, well, what are we doing in our transplant patients? There's surprisingly not a lot of procedural pause data out there, surprising or unsurprising. There is one abstract that was published out of Sentara, Norfolk in Virginia that looked at 13 patients. They put their patients on a protocol where it was written in stone based on their renal function, how long they would be holding the particular DOAC. And there is no bleeding or thrombotic events observed within that period using apixaban. Now, we can't always just hold the DOAC and hope it goes away. We have to think about reversal. And for DOAC, reversal has remained a very touchy subject. To think about it in the grand scheme of things, warfarin's been around since 1954, so a little bit older than my mom. She's not listening, so I can say that. But we didn't have a targeted reversal agent until 2013. Again, I will repeat that. We did not have a targeted reversal agent until I was a P4 in pharmacy school. So in the grand scheme of things, warfarin didn't have a very viable reversion option outside of FIP for a very long time. For us, we're a little bit quicker to the boot, okay? We can not only use 4-factor PCC, but we also have specific anecdotes in the vein of adairacizumab, which came out in 2015, and then andexanet alpha, which came out in 2018. So yes, the fear of a major bleed remains, but guys, we have reversal options now. We not only have non-specific reversal options in the vein of Kcentra and Fiba, and you can see that they work by targeting different vitamin K dependent proteins. We also have specific antidotes that bind or mimic the DOAC in a way that allows bleeding to be rapidly reversed. Now, we have updated 2020 guidelines from the ACC and expert decision pathways, kind of saying how we should manage a DOAC bleed. And a lot of times, reversal isn't always indicated. A lot of it is supportive care driven, just as we would see for Coumadin. But where reversal is recommended is in the setting of invasive procedures that are unsafe or urgent. So maybe transplant, ? We'll get to that data in a second. And then also in the setting of a major life-threatening bleed. And currently, these 2020 recommendations recommend first-line therapy with their adairacizumab for dabigatran, and then for anti-10A inhibitors, we have andexanet alpha, with alternatives being activated or 4-factor PCCs. But let's talk about that data for a little bit. So what makes these first-line options? So there are a couple meta-analyses that are available. This was a 21 study meta-analysis and systematic review that looked at studies that included PCCs and andexanet alpha. They had over 1,400 PCC treated patients and 396 andexanet alpha patients treated. And based on this and similar meta-analysis, there was similar effective hemostasis between the two agents in the setting of major bleeding, and then also similar but numerically higher thrombotic events in the setting of our andexanet alpha use. So again, broad brushstrokes are effective hemostasis was achieved in 77% of patients that were on PCC versus 83 that were andexanet alpha. And we can see that 11% of our patients in this meta-analysis experienced some type of thromboembolic event. Now, we have a couple additional things that have come out and regarding looking at the effective hemostasis. Again, this is a study that looked at andexanet alpha versus specifically 4-factor PCC, and they determined that effective hemostasis was seen in 82% versus 88% at 12 hours and 71 versus 76 at 24 hours for the two agents. Again, the 30-day symptomatic VTE rates were 5% in the Andexa group, much higher versus 1.9%. And then the 30-day total was about 10%. So again, not something we kind of seek and want in our transplant patients. Overall, the mean in-hospital mortality was 23% for the Andexa versus 15.8%. And this meta-analysis basically came down to it didn't really demonstrate a significant difference. But the next question is, okay, well, if we can use 4-factor PCC, that's what our hospital uses here for DOAC reversal. That's what our hospital uses, or used to use at UIC for first-line reversal, because andexanet alpha, in addition to causing clot risk, also causes wallet toxicity because it costs a lot. That's my joke for the day. You're welcome. How did these compare to 4-factor PCC in the setting of Coumadin? And it's kind of hard to extrapolate, but I pulled these images from the package insert, and basically you have an effective hemostasis rate of major bleeding about 72% of the time, and then in effective hemostasis in the setting of surgery, you have it about 89% of the time. So in the same ballpark, maybe a little bit higher because we have more demonstrated trials in the setting of urgent surgery, but again, still within the same zip code, but no comparative studies to date. But again, what are we doing in our transplant patients? We have 2 new studies, which are kind of highlighted in green. Aside from that, it's just a mishmash of case reports. The first study that I want to focus on is a study out of Spain that was a 53-patient heart study where patients were brought in on dabigatran and received adairasizumab reversal. And 7.5% required rehospitalization to control bleeding. And 66% of those patients required transfusion, which is maybe similar to the risk that you would experience for heart transplant, but that 7.5% take back to the OR is concerning. In addition to that, out of our colleagues from New York Presbyterian looked at, okay, well, we have 5 patients that were on apixaban and they went to the OR for a kidney transplant, and we gave them, drum roll, nothing. We gave them nothing, ladies and gentlemen. And for the most part, in the setting of no reversal, there was one patient that had an inadvertent major vascular injury intra-op, and then 2 patients received blood products. 1 patient underwent reoperation that just turned out to be a urinary leak that required revision. And then apixaban in this setting was resumed anywhere from 3 to 15 days post-op. And for the most part, 1 patient didn't resume because they were just a normal sinus and didn't need it. So take-home points, we have reversal agents, and we have the guidelines that kind of hold clout in how we should use them. Are we using them like how the guidelines should say is the question we should be asking ourselves. Do we even need to use reversal, as New York Presbyterian calls us to question? Undoubtedly, protocolization of DOAC pauses for procedures is necessary. And while the adairasizumab data is quite nice in a non-transplant population, the thought of dabigatran gives me a little bit of mild PTSD. So not something that I get very excited about. But in the setting of apixaban, you have 4-factor PCC, but we have to keep in mind that this is going to be a different kind of reversal potentially. We don't have that head-to-head trial to say. And with the thrombotic risk of andexanet alpha, that just gives us pause, as it should.
Sometimes I wonder if Alicia's actually fighting from my side and the cons against the DOACs here, because that was a great summary of some of the concerns of the risk with andexanet alpha. To highlight again, reversal risk is a timeline. We have several areas, as Alicia mentioned, that the risk for reversal is varied. So time of transplant, that's where I'm going to start off. What do we do with our reversal of our pre-transplant anticoagulation, and how does that dictate our choice of agent at that time? What about the perioperative setting? Atrial fibrillation postoperatively in the immediate periop setting is a risk, and it is something that we see. And how do we balance the need for anticoagulation with the need for possible biopsies or further procedures, as well as line-associated clots? Should we or should we not treat those? And then post-transplant, are biopsies protocolized or for cause, and how do we approach those? So, starting with pre-transplant, we asked what you prefer to use, and boy, did you answer. 4-factor complex concentrate, or PCC, as I will refer to it in this section, was resoundingly the reversal agent of choice. Alicia, it may not have been around for a long time, but boy, do we like to use it. And this is specifically highlighting the use of it in reversing warfarin for LVAD devices at the time of heart transplant. So we have used it, we have done it in a box different protocols, and it is published. Now, does anybody dare to differ? There are a few brave centers out there who are mandating using waitlist patients on DOACs. This was a very small percentage of our survey group. Of 115 responding programs, only 9 reported routine use of DOAC reversal agents, and some of those were in thoracic organs. This is specifically with talking about, as you mentioned, the dabigatran with idrusizumab reversal, and use of PCC for reversal of DOACs is reported as well, although 16% of centers do report canceling or delaying transplant due to inadequate hold time for the DOAC in the preoperation setting. So I think to summarize in this, at time of transplant reversal, we're just not quite there yet with our comfort in our DOAC reversal agents, as well as maintaining these patients and managing the thrombosis risk at the time of transplant. So I think this is one area where switching our patients to warfarin in the pre-transplant setting and having the availability for PCC reversal at time of transplant is maintaining as our standard of care. Now, what about post-operatively? Each organ confers its own risk of atrial fibrillation in the post-transplant setting, though in the heart transplant setting, the picture is complicated with the setting of ischemia time during the transplant and rejection as possible other additive causes. Venous thromboembolism, or VTE, is, after transplant, certainly another risk and is reported frequently across the organs. Acuity of the clot is determined by its time post-transplant and its location, as well as any factors that may have contributed towards it. And there are several factors that transplant specifically do increase that VTE risk, including something that we address on our daily rounds, specifically our immunosuppression choices. Luckily, our mTOR class discussions usually don't happen until further post-transplant due to concerns for wound healing, but it is a black box warning for hepatic artery thrombosis. And in a database-wide review of mTOR adverse effects, Nguyen and colleagues found that mTORs were associated with an increased risk of vascular adverse events, including VTE at a proportional hazard. Transplant patients also have increased hospitalization and increased risk for malignancy that also increase your risk for VTE. So what happens and when do we anticoagulate? One question that arises often in patients with prolonged hospitalization and line burden is what to do for those pesky line-associated upper extremity clots. Levy and colleagues analyzed the risk for pulmonary embolism with or without anticoagulation for these upper extremity DVTs. A very small incidence of PE was noted at 1% and raises the question for these patients and these indications, should we even pursue anticoagulation? And honestly, at our center, it's sometimes something that we do defer. However, in transplant patients specifically, we can't forget about the risk of the lower extremity clots. The choice to anticoagulate below the leg is quite clear. However, no assessment of the upper extremity clots have been reported. If a lower extremity clot is found, anticoagulation is certainly recommended due to an increased risk of pulmonary embolism without it. Now, to add another layer of gray to our black and white picture is the biopsy dilemma. So, centers have varying protocol approaches, including for-cause biopsies as well as protocolized biopsies as the standard of care. Sometimes these protocolized biopsies can be as often as every week. When we're talking about those hold parameters that Alicia was referencing earlier, you're talking about holding that DOAC 2 to 3 days before a procedure, and then usually 24 hours after a biopsy. Majority of the week, these patients are not even getting anticoagulation, and raises the question of the risk of having them off of anticoagulation for that long. When patients' biopsies are for cause, we do need to think about how to safely and quickly reverse these agents. So again, though PCC may not have been around for a long time, there were options that we were able to use before this. This was not something that we were blindly working with before the advent of 2013. So I've listed here on this slide several agents for highlighting the time to effect for these various agents as long as the thrombosis risk. For more urgent bleeding and more urgent situations, this is where we do need to talk about fresh flows in plasma, or FFP, compared to PCC, because you notice that the time to effect is immediate for both of these. However, they do confer separate risks. So colleagues, Chai Ascadopa and colleagues compared the use of PCC with fresh flows in plasma in order to a meta-analysis of 13 different trials. And PCC stood out as the winner here. This was associated with a significant reduction in all-cause mortality, as well as a more rapid INR reduction. And this is the key one that we run into with the FFP, less risk of volume overload without an increased risk of thromboembolic events. Alicia was referencing some of this earlier. We can even use PCC for those DOAC considerations, and there have been small experiences reported with single center retrospective reviews, highlighting especially in intracranial hemorrhage, one of our most serious bleeding events. For our patient, MR and colleagues, they found no difference in the functional outcome or thrombotic events when comparing andexanet alpha to PCC in patients with factor Xa related intracranial hemorrhage. However, Megan Barra and colleagues here at Mass General did find higher occurrence of good hemostasis and excellent hemostasis in patients who received andexanet alpha. However, patients receiving the 4-PCC had lower pre-reversal GCS scores and a larger pre-reversal volume. So this was chosen in those patients that are more complex with a higher acuity. So since I'm going to be talking about enoxaparin throughout this presentation as well, I certainly want to quickly remind you of the availability of protamine for a reversal of active bleeding in patients on enoxaparin. Typically, we don't talk about enoxaparin reversal because it has a short half-life, and this is an agent that we can hold 24 hours prior to the procedure or biopsy and restart pretty quickly afterwards without having that concern for the long half-life. However, if there is an active bleed and it has been less than 8 hours for the dose, there is some dosing listed on this slide here, as well as it'll inhibit about 60 to 75% of the enoxaparin activity. However, please do not forget to give it slowly, as there is an anaphylactic risk when it is given faster than 5 milligrams per minute. So, to sum it all up, we don't want to risk going too far. Don't forget about that thrombic risk associated with andexanet alpha that Alicia so nicely summarized. The current practice standard for reversal with 4-factor PCC at time of transplant, and those centers are starting to explore DOAC reversal agents, we certainly have to tread with caution in terms of whether we A, use them at all, or B, worry about that prothrombic risk. Other agents are still available, such as vitamin K, fresh frozen plasma, and protamine for our non-DOAC uses. They just might not work as quickly as we would hope. With prolonged hold procedures and protocolized or non-protocolized biopsies, we may find that these patients are holding their anticoagulation more than they are receiving. And short half-life medications such as enoxaparin and heparin do remain the gold standard for patients with a high risk for interventions in the immediate perioperative setting. I think you're on mute, Alicia.
You would think after a year and a half, I get it right? No. But what I was saying was, you show me a program that biopsies their patients every week, and I show you a program that picks slowly away at an allograft until there's nothing left. Dear God, not even our lungs do that here, Georgina. What's happening over in Boston? Talk about East Coast attitude, my goodness. So next, round 2, monitoring parameters. So we have a lab coagulation monitoring test to kind of assess kind of the overall anticoagulation picture of our patients. A majority of what I'm going to focus on is talking about the APTT, the anti-factor 10A, which is concentration-dependent inhibition of factor 10A, dilute thrombin time, which is diluting plasmin and make it more sensitive than thrombin time, and then the acerine clotting time, or the ECT, and that measures thrombin generation. And really what we're looking at is the 3 different phases that kind of can exist within the coagulation cascade, which is basically the initiation, propagation, and then fiber and formation of a clot. And you can see here, depending on what agent or what lab test you're looking at, you're kind of getting a snapshot picture of a different setting. So in our DOAC patients, we have multiple options to pick from, but what it comes down to is a lot of those options you shouldn't really look at. You can't look at INR. It means pretty much nothing. Can't look at APTT. It might be increased, but the correlation coefficient is garbage. It's basically what I might get on my BCTXP, so we can't rely on it. What we can rely on for our dabigatran is going to be our DTT and our ECT with these very high correlation coefficients. And these are going to be our quantitative assessments. We have data to say that increased trough level of a DTT is associated with bleeds. And then we also have increased ECT 3 times the upper limit. It's also associated with bleeding. So we have these spot tests to say, okay, patients on therapeutic anticoagulation, what's happening? Is it safe? Is it not? In addition, for our factor 10A, again, we have this highly correlative anti-10A that when it's calibrated, it can be used as a quantitative measure, and it is increased in the setting of therapy. And we can not only look at troughs, but we can also assess peak-dependent effects of agents as well. Now, this is kind of where we get into the lack of just data in general. So you can Google University of Washington DOAC, and you can pull these very useful therapeutic ranges for rivaroxaban and apixaban. They don't have any for dabigatran. And, you know, some centers might use them to guide therapy or just say, like, is it appropriate? But honestly, we don't know. We have no idea. They're wide therapeutic range. This is where we think they should fall. We don't have data to say above that, bad, below that, also bad. So I'm just going to do you a favor and just let Kevin speak what my heart is trying to tell you. We have no idea. But with these monitoring parameters, do our patients fit in the box? Maybe. So this study out of the United Kingdom looked at the incidence of patients that were in the expected ranges per the International Council for the Standardization in Hematology, or ICSH. And they had 31 kidney transplant recipients taking DOACs, and 8 of those patients had creatinine clearances less than 30. Overall, 94% of the DOAC levels were in the expected ranges. So yes, this patient might look highly questionable on paper, or yes, like, you know, we are worried about them being on a DOAC, but 94% of the time, it's going to be okay. So maybe the answer is maybe we should have some data to tell us that this should be something we guide our data. Do we have it? No. In this particular analysis, the bleeding rate was 6.9 per 100 patients. So my take-home points are kind of short. This is a very brief round for me. We have monitoring parameters, but the data with regards to how we use them, is very wishy-washy and for the most part non-existent. For the most part, you can tell if a patient is on therapy, but that's usually where it stops. Again, wide therapeutic range. There's also current guideline recommendations that do not routinely recommend therapeutic drug monitoring, but smart exceptions can be determined, for example, in the setting of drug interactions or patient extremes. But it beats coming to clinic and checking INR every day, maybe weekly, or having home testing. And for the most part, having that extra step of monitoring, getting rid of it is a great burden relief for patients. And for the most part, we are able to do it in a vast majority of our transplant patients.
Monitoring. Let's be honest, it's our favorite thing as transplant pharmacists. We love knowing exactly what's going on with our medications and the measurable effect it's having in our patients. And there's no greater example than a tacrolimus level and the INR test. Now, we are living in 2021, so technology has advanced to the point where being on warfarin doesn't mean a trip to the lab every few days. Point-of-care testing is available in patients' homes. Though please remember that there are reported discrepancies when the INR is greater than 3, which will trigger a visit to the lab. Sound like gene expression profiling to anybody? So these laboratory tests are confirmatory and they are the gold standard. You are familiar with the wide availability and turnaround for INR, although it does require venous puncture. So do most of our labs. I want to highlight an instance where we don't trust the INR, though, and that is in the setting of lupus anticoagulant or antiphospholipid syndrome. In these situations, we do still have other options. We can do chromogenic factor 10 monitoring, which requires minimal phospholipid for analysis and is reported as a percentage of activity. Please remember that the higher percentage means more anticoagulation, and our typical goals are 20 to 40% for an INR of 2 to 3. All this monitoring does have a benefit. Frequent touch bases with the healthcare team and follow-up can lead to increased adherence over DOACs. This was an analysis of British prescription fill histories for patients on atrial fibrillation over the first year, and warfarin noted in the blue line had a significantly higher fill percentage over 12 months than the DOACs. However, I would take this with a large grain of salt, given that these were not transplant patients who are already checking in with us very frequently as healthcare providers and already get a lot of monitoring, and non-adherence causes are so multifactorial. So talked about, but wouldn't raise my hat on it. A good compromise of minimal outpatient monitoring while still being able to control or monitor for patient-specific reactions to medications include using anti-10A monitoring for enoxaparin. This wouldn't be an anticoagulation talk without including a coagulation cascade. And as you can see in the right, the low molecular weight predominantly acts on factor 10A, unlike heparin, which works on both factor 2 and factor 10A. So by preventing 10A conversion of prothrombin into thrombin, we can measure and monitor peak levels of this to establish the activity 3 to 5 hours post-injection within reference ranges that have been validated, unlike in some of our other DOAC medications. Pharmacists have used this monitoring in special populations to focus on many different special populations, including obesity and trauma patients. However, we've also used them for transplant. I'm going to highlight some of the great data that's been published by our team of transplant pharmacists, including the first trial from Moten and colleagues that included all types of transplant, but mostly young, and reporting a reduced dose of 0.8 mg per kg every 12 hours was associated with an anti-10A of 0.98. Though further reduction may be necessary, as even with this reducing, there was still 44% reported occurrence of supratherapeutic levels, though no patient did exclude major bleed in the total population. Bleeding was noted numerically more frequently in the liver and lung patients, but this did not reach statistical significance. Sofjan and colleagues from the Barnes-Jewish reported a similar effect strictly in their lung transplant patients, and their role was to reduce the dose to 0.76 milligrams per kilogram every 12 hours. And they did assess bleeding events on those low dose versus standard dosing. Though not statistically significant, there was a trend towards less bleeding in the reduced dose of 10.5% versus 17%. For our pediatric colleagues out there, there's an excellent paper from Dame and colleagues, which assessed a dose of 50 units per kilo every 12 hours. They found that body weight dosing was more relevant than renal function in our kiddos, which is different than the dosing that was recommended by the package insert for infants greater than 2 months. So definitely would recommend reading this article, as they did a great pharmacokinetic model and prediction. Lastly, in our heart transplant patient group here at the Mass General, we actually found that a reduced dose of enoxaparin of 0.6 mg per kg every 12 hours resulted in a correlated 10A value of 0.75 with a Rho coefficient of 0.82. So this is all to say that you don't have to come to warfarin clinic to be safely monitored. And yes, there are times when you can't trust an INR, but for those patients, we still do have options. Easily available and validated monitoring allows for patient-specific dosing and is especially important in our transplant population.
Thank you for that lovely drug talk sponsored by the data, sponsored by the Massachusetts General Hospital. If I had a nickel for every time Georgina mentioned her own data, I could buy a sandwich. Not a very good sandwich, but a sandwich. So with that, we have our round 3, which are our drug interactions. And honestly, this is where Georgina and I share a lot of common ground. You, me, same. We share key drug-drug interactions, though. And for us, while we lack the vitamin K dependent and diet interactions that do exist, there's many overlap. And the impact of many of these interactions are sometimes difficult to assess, namely given the wide therapeutic window and monitoring parameters that we have within the DOAC family. Again, the pharmacokinetic interactions with moderate CYP3A4 and or PGP inhibitors are associated with increased risk of bleed. But again, their overall impact and how to kind of act on that drug interaction are not as well defined. So for us, when we think about our DOAC drug-drug interactions, really we need to contend with what we're dealing with. I will give Georgina a little bit of slack on the rope to say that if we do have an inducer, I can't use a DOAC. I can't. We don't want to run the risk of treatment failure. We don't want to run the risk in that way. But knowing that there are specific package insert prescribing, for example, apixaban recommending specific dose reductions, we can kind of pursue. We know that there might be increased effects and significant decreases again, but knowing who and when and how, or potentially monitoring those patients is a good first step. So obviously you need a pharmacist to review the med list. That doesn't go away. My job doesn't stop. You can't just put somebody on a DOAC and say, great, it works. You need to use your brain because these are metabolized very similarly. However, the grace that the DOACs give you is very broad and wide sweeping in a lot of different ways. We know that we can use azoles, which out of all the drug-drug interactions you'll see in the post-transplant setting, maybe outside of cyclosporin, is going to be significantly common. And we know that fluconazole, there was some increased major bleed risk in patients receiving DOAC. Now, a lot of them have no empiric dose adjustment, can be recommended universally. Again, each azole has different inhibition capabilities, but the apixaban prescribing insert does recommend a 50% dose decrease when co-administered with strong dual inhibitors of CYP3A4 and PGP, which includes ketoconazole and itraconazole, which ITRA we see quite often in our post-lung transplant setting, but it's really unclear what we do when we want to extend or change fungal coverage to posaconazole, VORI, or isobuconazole. What we do here at UCSD, although it's not published, is we do look to our anti-10A peak and trough levels to say, how far out of range are they, or are they in range with empiric dose adjustment? So it gives us a little bit more weight to our recommendation, although that's something that data collection is ongoing for. On the flip side, and with regards to antiplatelet, there was a meta-analysis of the DOAC non-valvular atrial fibrillation trials and the registry data, and it suggests that the use of DOACs and aspirin have less bleeding risk than those of vitamin K antagonists and concomitantly with aspirin. There's also randomized data from patients, again, with atrial fibrillation undergoing percutaneous coronary intervention, and they demonstrate that DOAC plus a PGY12 inhibitor together had a similar efficacy and potentially reduced bleeding compared to when warfarin was used instead. So how does this translate to transplant, right? What do? We have some data. It's kind of vague. Well, it turns out we just take the Eric Cartman approach and we just do whatever we want. We don't know. Sometimes we'll reduce if there's two drug-drug interactions. Sometimes we'll avoid. Sometimes we'll reduce the distance setting of cyclosporin. It just turns into a big old whatever, I do what I want. And that's just transplant. So for us, our take-home point is we have this impact of drug-drug interactions. We know that exists, and we know that they can impact drug levels, although our data to say how that is impacting a wide therapeutic range drug is limited. It is permissible to use with other antiplatelet agents, a DOAC, but everyone's really kind of doing their own thing, regardless of the prescribing information, as no one is also sharing these experiences. So we have these unique practices, we have these unique things that are going around, but no one's really saying, well, we do this and this is what we've seen. And that's kind of a shame because it leaves a lot of us kind of in the dark. And we need to stop thinking about DOACs again like warfarin. Warfarin is a narrow therapeutic index drug, and we need to kind of broaden our mind in a sense for what drug-drug interactions have an impact on DOACs, which have a much wider range to work with acceptably.
Interactions. You got me. I admit this is where you have me. I acknowledge the over 200 reported drug interactions with varying clinical significance. Alicia did a great job of summarizing the PGP and CYP3A4 interactions that we all know and love. But I do want to remind you that for warfarin, the primary metabolism of the S enantiomer is actually through CYP2C9. Listed on this slide are inducers and inhibitors, which some of them will look familiar as they overlap with CYP3A4, such as voriconazole. However, there are some to remember, such as sulfamethoxazole, trimethoprim, and metronidazole that we will use in our transplant patients, but do not typically think of in terms of drug interactions. And you can't talk about warfarin without also talking about diet. It's true. Those pesky greens are a problem. However, consistency is key. And I do want to remind everybody that diet doesn't just apply to warfarin. It applies in terms of supplements and herbal medications for any patients on anticoagulation. So please do remember to talk to your patients about some of these supplements and counsel them on the increased risk of bleeding with some of these herbs. But there is an upside. We can monitor these drug interactions. And there's significant amount of published data on the potency of these interactions that can be dose dependent, route dependent. We've learned so much through the published data of these drug interactions that we've even applied to our tacrolimus and calcineurin inhibitors. There is also an agent that does anticoagulate without any drug interactions. It just needs to be injected. So don't forget about enoxaparin if you're stuck in a really tough drug interaction pickle and need a temporary solution. However, monitoring for a more long-term anticoagulation would allow for oral usage. So round 3, DOAC drug interactions do leave us blind and can be high risk until we see all that data that Alicia's been hinting at. We have lots of data on what to expect with these interactions with warfarin and the degree that they'll affect our patients for non-DOACs. But yes, we need to factor in diet, but we can easily monitor.
And this kind of leads us to our final gray point, our extreme populations. So again, not all DOACs are created equal. And when we think about extreme populations, to highlight kind of our biggest concern when this DOAC survey came out, it was our patients' renal function. In the setting of rivaroxaban, we know that there is higher rates of bleeding when used with non-valvular atrial fibrillation, especially for patients on hemodialysis. But when we think about apixaban, which has a lot lower renal clearance, about 25 to 30% relative to others, which have a lot higher clearance dependency. There have been several meta-analyses that support the use of apixaban specifically in an ESRD hemodialysis population. The first meta-analysis looked at warfarin and found that when compared to apixaban, there were similar rates of ischemic stroke, similar rates of major bleeding, similar mortality, and had a significantly higher risk of hemorrhagic stroke. And this was kind of seen. In addition to that, we had one really good trial that was our kind of bastion that we are going to say this will be the final answer, and that was the Renal Af Trial. It was a randomized trial of hemodialysis patients to either apixaban 5 daily or BID or warfarin, but it was stopped early due to slow enrollment. But based on this preliminary data before trial termination, again, likely prone to type 2 error, there are similar rates of both major and clinically relevant non-major bleeding, and a large proportion of warfarin patients were subtherapeutic, in addition to the under-enrollment that led to type 2 error, more than likely. In addition to that, another kind of downside of the DOACs is we can't necessarily use them safely in our liver disease patients. In patients that have liver disease, you can see that there are drastic modifications to the CYP metabolism capabilities. And in this setting, just no thank you. I see liver disease, I see cirrhosis, I will automatically go to Coumadin, or I will automatically go to enoxaparin. I fully accept that this is not a box that DOACs belong in. In addition to that, we have our body habitus. We have our large patients. We have our cachectic patients. So for us, you can see that there are pharmacodynamic and changes as a result of being either increased obese, more than 120 kilograms, or cachectic, meaning less than 50 kilograms. What this means in terms of data, we have two higher BMI studies, the first being a systematic review and meta-analysis that looked at patients on DOACs versus warfarin. And they found that our patients that were underweight were at an increased risk of stroke or systemic embolism. And for the most part, they found that overweight obese had a reduced risk of that stroke or systemic embolism. So for the most part, if you were on a DOAC and you're overweight or obese, you had these reduced rates. And there were, for the most part, a reduction in all-cause death if you were on a DOAC. Compared to those who are on warfarin, patients on DOACs who are underweight, normal weight, or overweight had significantly decreased risks of SSE and major bleeding, while those patients who are obese within the context of this meta-analysis, DOAC users were at no higher risk of SSE and major bleeding. Now, flipping over to the VTE side, a publication again out of the University of Pittsburgh that looked at 1,840 adults with VTE who received a DOAC or Coumadin, found that there is no significant difference in the recurrence of VTE between the patient populations, and there is no significant difference in the occurrence of PE and DVT that were seen between the DOAC and the warfarin-treated patients. And bleeding occurred in 1.7% and 1.2% of patients in the DOAC and warfarin arms, and there is no statistical significance between those two groups. Again, not all DOACs are created equally. Again, elderly patients for the longest time do give us great pause. And there are two meta-analyses that I would like to point out. The first looked at different DOACs compared to warfarin and found that there is no significant difference between DOACs and VKA in the composite or majority of patients having like a negative safety outcome. So they are similar in that regard. And there is a significantly lower risk of intracranial hemorrhage and a significantly higher risk of gastrointestinal bleeding. So they're less likely to bleed in the head, they're more likely to bleed in the gut. Again, this is including all DOACs, not just a single agent. In addition to that, the second meta-analysis that looked at these DOACs in our elderly patients in the setting of prophylaxis of stroke or systemic embolism, apixaban was found to be the best among the DOACs. And reduction of the risk of major bleeding, again, apixaban was found to be the best out of the DOACs compared to Coumadin, although both of these cases not statistically significant. In safety composite-wise, apixaban was ranked to be the best out of all of the agents, including Coumadin. So with that, not all DOACs are created equal, so why just not start with apixaban? And there was this helpful study out of New York Presbyterian that our moderator, David, authored that showed a lower cumulative incidence of bleeding in the setting of apixaban compared to other DOACs, and a lower cumulative incidence of major bleeding was similar. So again, just less bleeding, and for the most part, the N of major bleeds was so low, likely confounds with the type 2 error. So dosing was in this trial was congruent with package insert and was associated with lower risk of thrombosis. So take-home points. Apixaban demonstrates the most robust and best efficacy and safety data out of all of the DOACs versus warfarin when we think about these outlier populations. So again, when in doubt, pick me, choose me, love me, pick apixaban. Unless you have all of these other outstanding issues at the bottom, and then you should probably be on warfarin or enoxaparin, as Georgina recommends.
Yeah, so we can't ignore the extremes, and this is where experience and comfort do shine, though there are significant concerns with DOACs. I do want to be respectful to everybody's time, so you'll probably be able to expect what I'm going to be saying for all of these extremes. Monitor. We can monitor. We can consider an INR. Please consider an anti-10A. And for different sizes of body habitus, consider starting warfarin doses higher. Obesity has been reported to be protective against bleeding with warfarin, but please monitor. In terms of end organ dysfunction, as Alicia highlighted, with renal impairment, warfarin, no dose adjustments. However, enoxaparin is contraindicated with creatinine clearance less than 30. And I do want to address, there was a question in the chat about if we would ever consider using enoxaparin in a patient with ESRD and anuric. And honestly, I would say that I would never, I don't know if there's any situations where I would consider that, just from an anuric perspective and concern for just continual accumulation. From a hepatic impairment perspective, enoxaparin does not have dose adjustments, but warfarin is the only recommended oral anticoagulant in patients with child's PUC. And the elderly, please, these are fragile and handled with care. And these are reduced starting doses. And again, I can't say enough. Please just use these agents from a monitoring perspective. So some take-home points for these extreme populations. Hepatic insufficiency is a factor, but it can be monitored with warfarin. Renal insufficiency contraindicates indicates the use of enoxaparin, but had no effect on warfarin. But what will you bridge with if needed? Will it require hospitalization? This may be an instance where we have reliance on some of our DOAC agents. Increased BMI is acceptable patient factor that can be considered DOAC friendly, but also for our bleeding risk, we want to make sure that we continue to monitor these patients and adjust our doses as possible. Elderly patients may benefit from keeping a closer eye as bleeding risk does increase. And when in doubt, please monitor with agents that you can monitor on. So it seems that Alicia may be having some technical issues from a internet connection perspective. So I'm going to go back to her slides and continue with my wrap up. So let's focus on the devil you know. Each patient is unique with their own challenges, and there's an extensive amount of published experience of pharmacist involvement in anticoagulation clinics, specifically managing warfarin, etc. Just because there's no difference in a bleeding or stroke outcome doesn't mean that we need to jump on board to the DOACs right away. And extensive literature is surrounding use in nearly every situation with our warfarin agents as compared to our DOACs as we start to get to know them. So if there's any question about it, don't be afraid to jump back to the comfort and familiarity. Re-highlighting some of these downsides of the DOACs, we need to discuss and really decide, do we actually need anticoagulation for some of these patients? Some of those pesky upper extremity line-associated provoked clots, maybe somebody we can avoid this increased risk with. Let's monitor and choose therapies that we have experience with and reverse without overdoing it, as well as having interactions that we can monitor. And when experience matters, stick to the agents that have the most reported literature and most reported experience. At the end of the day, we have solid agents that have a significant amount of evidence and published experience with. Though there are newer progressive agents, they are not the best fit for every patient. However, Alicia has brought up some really great points throughout this debate. And as I said, there are certainly situations where I will jump to DOAC. But at the end of the day, the best person to make decisions regarding your patient's anticoagulation is you. So with that, I will see if Alicia is able to do her summary wrap-up now.
It seems like Alicia is still trying to connect from a different computer. I think what we could probably do for right now, first of all, thank you both Drs. Lichvar and Waldman for this wonderful debate. You really did a really good job reviewing the data, both the pros and the cons of DOAC use in SOT patients, as well as some of the considerations here for using warfarin. And I thank you both for that. Just a couple of quick notes that we didn't get to in the beginning because I had my own connectivity issues. I feel like both Alicia and I will be IT pros by the end of today. If anybody in the audience has any questions, please submit them using the chat functionality on the left-hand side of the screen, and then I can ask them here. There will be an evaluation for this webinar at the conclusion of this presentation, and we encourage you to complete this and let us know how we did and how we can improve on our webinars in the future. And the slides from today's presentation will be posted on the ACCP website in the section titled Webinar Slides after the presentation. This is being recorded. So Georgina, why don't you get us started here? Alicia reviewed a little bit about her approach to protocolized biopsies in the centers in which she's worked with. How do you deal with protocol biopsies in patients that are on DOACs?
In patients that are on DOACs, we have specific cutoffs and specific time points following the ACC guidelines around renal dysfunction. Honestly, we tend to avoid DOACs and the perioperative time when we are having more routine biopsies because those longer hold periods that can sometimes lead to them being off anticoagulation more than they're on it. So this is an area where we found a lot of help with our use of enoxaparin in a sort of temporizing measure where we do that when they're getting biopsies throughout the 13 months. However, when they space out to monthly biopsies and beyond, we use explorable options and sometimes associated DOAC, and sometimes it's preferred to
Okay, and
sorry about that, David. Can you hear me?
Oh yeah, we can hear you. Welcome back.
I almost got abducted by aliens, but it's all good now. We're fine. I fought them off. Sorry about that, everybody.
No, it's no problem. Welcome back. And actually, the next question I think is going to be for you. You reviewed the published data on reversal. What is your approach to reversing 10A inhibitors prior to transplant? And do you use TAG or Rotum in your decision tree?
So I can speak to kind of my last institution, then also to our current one. At UIC, we did not commonly or typically reverse in the setting of our abdominal transplantation. We had a movement kind of with our practice to kind of switch some of our patients back to warfarin as we were accepting a higher risk of PGF patients, and our surgeons did feel more comfortable with that particular anticoagulation at the time of surgery. And at UCSD, where I'm currently at, again, we are a no reversal center for our abdominal, specifically kidney transplant. And with our liver in both institutions, we did not have leadless patients on DOAC because why would we? In the setting of pancreas, again, because of the thrombosis risk in that particular allograft, we forewent any type of reversal at my last institution. And then also here, I have not seen, DOAC used in the setting of thoracic transplant. They pre-op tend to be more of a Coumadin using center. And then on the abdominal side, if they are on a DOAC, again, they are no reversal. So I think, clear delineation based on my practice experiences if we're abdominal, and if it's not some vascularly complex acrobatic case, and it's in the setting of kidney and pancreas transplant, I would go ahead and forego kind of reversal in that setting, maybe accepting the fact that you might need additional blood transfusion, but for the most part, would not recommend routine reversal.
Okay, thank you. The next question, what is your general approach for trying to pick an agent in the immediate post-transplant period? You both sort of highlighted that there's a higher bleeding and clotting risk. There's higher rates of AFib and just VTE overall in transplant patients. Just walk me through the decision tree of when is it time to start a DOAC, if you're going to start a DOAC, or what is it the intervention you're making on rounds to suggest warfarin instead?
I mean, I really think, there's a lot of things that go into that multivariate analysis for me. I think first and foremost is kind of thinking about what might be the biopsy needs of this patient. An abdominal example that I think of is we transplanted a positive cross-match patient. We gave them maybe plasmapheresis at the time of their session. Well, their risk of AMR is quite high. So you have this, well, if I start them on a DOAC and they need plasmapheresis, I'm going to have to switch them off and switch them to something different anyway. So I think it's first kind of looking at, the overall composite of the patient. What is your worst case scenario? The second is, again, outside of, what it might be their biopsy needs, what might be their treatment needs, what drug interactions are they on? For myself, in my own personal treatment algorithm, one drug interaction I'm willing to contend with. Once we get into the 2 or the 3 range, it becomes a very nuanced discussion. Again, you can check, anti-10A peak and troughs, what that means in the setting of a calibrated assay and how that translates into your patient in front of you. It's less clear what the data says. But that's generally where I draw the line in the sand, is usually over drug interactions. The third is, kind of what is their history, um, and what is the worst case scenario. So, a vast majority of time, I am able to keep my patient on a DOAC, but for me, that line in the sand kind of starts floating around the multiple drug interactions, the higher risk transplant patient that might be requiring AMR treatment or might be requiring sequential biopsy, kind of outside of what we would see um, be in a normal protocol. So again, that looks different at every center, but it's also what are you willing to contend with, and as a center, how short your follow-up is with those patients. What is your clinic interval? So there's a lot of things, but I think it boils down to those specific 3 factors. And from there, it's having a very engaging conversation with the rest of the multi-D team, and then also the patient. For just because we think the risk is acceptable doesn't mean that they think that risk is acceptable. So engaging that patient in that conversation also.
Yeah, I'd say my approach is similar. I think one of the things that I factor in most is time post-transplant, as normally when these discussions are happening, I'm mostly spending most of my time inpatient rounding on these patients. So these discussions are about what is their risk for OR takeback and bleeding complications. Are they far enough out where we feel comfortable that they may not need an urgent procedure, a new chest tube placed for our lung transplant patients, for example. So this is something I factor in, as well as the drug interactions, certainly in consideration. And I really feel uncomfortable when having to use strong azels with DOACs, as well as especially once you start adding up those drug interactions. It doesn't feel like we can have a great validated method of monitoring them. And this is where we do use a lot of enoxaparin in these settings, as well as factoring in follow-up and adherence. And during time out from transplant, I think is huge. When they're outpatient, more stable, less frequent biopsies, less likely to need urgent biopsies for concerns for the graft. then I feel more comfortable initiating the DOAC discussion.
All right, great. Thank you so much for your presentation and for the Q&A today. We've officially run out of time, so this will conclude our 9th webinar in our ACCP series. So thank you all for joining today. Have a great rest of your day, and be sure to take a look at the recording on the ACCP website. Thank you.
Wonderful. Thank you all. Thank you, Alicia and Dave.
Bye, Georgina. Always a pleasure seeing you both.